Welcome everybody to tonight's webinar, Advanced Care Planning in a Pandemic. My name's Katie Pryor. I'm the Manager of the Education Programs here at the Western New South Wales PHN. I'd like to start tonight's meeting by acknowledging the people of the Wiradjuri Nation and the different nations on which people here sit tonight. I would like to acknowledge that we work on the traditional lands of many Aboriginal clans and nations and pay respect to elders past, present and emerging, and acknowledge their continuing connection to land, water and culture, and for their contribution to help shape the life of the communities in which we all work and live. We are committed to working in the spirit of partnership and collaboration with our region's Aboriginal communities and peoples to improve their health, emotional and social wellbeing. I welcome Aboriginal and Torres Strait Islander Australians who are present in this meeting. I'll just run through a bit of housekeeping. This webinar is being recorded this evening and will be available on our website within a day or two and will be under the Events tab on the website. Everybody's on mute tonight to optimise the sound quality, but we really encourage your questions and comments, so please use the question box and the chat box. For any questions that you'd like put to the panel discussion, please put them in the question panel. Any other comments or direct questions to our presenters, can you just please pop them in the chat box, which is just here in this small little triangle. If you can't see your control panel, it might be minimised. If you look to the right-hand side of your screen, find the little orange arrow, click on that. It should open out your panel and then you can go to your questions and your chat from there. This evening, Dr. Ivy Chua will be facilitating our webinar. Ivy is one of our GPs from Dubbo. She's the chair of Western New South Wales PHN's Western Clinical Advisory Council, the Rural Clinical Lead for New South Wales Health's Primary Care Communities of Practice, the GP Lead for Western New South Wales PHN's COVID-19 response, and a clinical editor for HealthPathways. Ivy is passionate about rural health, fostering a patient-centred approach to healthcare, continuous quality improvement, and collaboration across healthcare sectors. And we thank Ivy for joining us this evening, and I'll now pass over to Ivy. Thanks, Ivy.
Good evening, everyone. I have the privilege of introducing Louise Brown on tonight's webinar. Louise Brown has been employed with Burke Hospital for the past 16 years. Louise's passion is working in palliative care, and in 2017 she was recognised as a Western New South Wales Local Health District Staff Member of the Year finalist for her delivery of outstanding service in support of Aboriginal patients, carers and families. In 2019, Louise was appointed as the Aboriginal Health Worker Palliative Care for the Western New South Wales Local Health District. Louise is a role model for promoting positive cultural change and inspiring staff by her consistent promotion of Aboriginal cultural awareness, respect and compassion. As Louise is delivering her presentation this evening, please feel free to type in your questions into the chat box, but what we will do is actually address those questions in the panel discussion towards the end of this evening. I'll hand over now to Louise Brown.
Good evening, everybody. I'd like to make acknowledgement to country and to Aboriginal people who may be viewing this or listening to this evening, and pay my respect to past, present and future Aboriginal people. I'm Louise Brown. I'm at Burke. I'm a Kamilaroi woman, and firstly, I'd like to say that my passion is palliative care, and I love working in with Aboriginal people, showing them, leading them, and also with my medical team, nurses, doctors, allied health. All support is given from me to anybody who's in this arena. My first question is like to engage patients, especially those who are vulnerable. Well, can I just let you know that with Aboriginal people going into palliative, they really don't recognise being palliative. The only thing, the way Aboriginal people recognise palliative, if you have got cancer, but if you haven't got cancer, you've got chronic illnesses, they don't recognise palliative care. They think, oh no, you don't need it. And, you know, I try to encourage them, no matter what you got, chronic or cancer, it's all still palliative. And working in with advanced care plans, they don't really acknowledge that much either. They just say, no, well, we'll just do it this way, kinda. Developing knowledge of current advanced care planning. Well, like I just said, you can show and talk with Aboriginal people about advanced care planning, but they really don't take that on board, like they don't take palliative on board as much. But you know, when someone is close to dying and whatever, you might have the patient in the hospital, and one thing is that you'll get all our mob coming. You mightn't see them through the process of this, and they'll be away until the last minute. When you have Aboriginal people dying in your hospital, you'll want them, they'll all want to come no matter what. Whoever's laid in that bed, that is the person they need to see. And sometimes it can get a bit too much for staff and that to have a lot of Aboriginal people around. But with COVID at the moment, you still get a lot of Aboriginal people who want to be in there, but they can't. And I find it very difficult for doctors, nurses, Aboriginal health workers who's in the hospitals and working with people in this area. It's very, very difficult when you've got Aboriginal people dying in the hospital and the family just want to get there no matter what, but they can't. And it's really hard to explain to them that we're in COVID and these things just don't happen anymore like they used to. Supporting patients with advanced care in a cultural appropriate way. I'll tell you one story about that. I had to go to Dubbo once to a patient who was there, travel from Bourke, and this family, there was a lady there who was dying, and she and her family didn't want to go to another hospital. Oh, well, we'll send you to another smaller facility, send you back where you was transferred from. And so the general manager called me in and said, Louise, you need to come down to check all this out. So I drove down there and I got there and I seen the general manager. Then I went and seen the nurse manager. Then I seen her sisters who was there on site, spoke to them, and they said, all we need is what our sister wants. And then I went and spoke to our aunt who was laying in the bed. I said, Aunt, what's going on? You know, why are you mucking up? Why ain't you going here or going there? She said, no, I want to go home to country. And I said, where's your country at? She said, Broken Hill. But the doctor told me that it was too late for me to go. So I said, look, we can organise a air ambulance to fly you home back to country, you know. And sometimes it's misinterpreted about where people come from. You might originally come from one town and you may have lived there for 20 odd years or more, but going home to country is a different thing. So you really got to ask the patient where they come from, what country they, you know, what town they come from. It may not be the person they was when the patient was transferred from that town. It may not be that. And this family was not very happy about what everything was going on, and you know, they only wanted what the patient wanted. But I said, Aunt, I can organise this for you if you want to go back to Broken Hill. She said, no, the doctor said it's too late. And then I went back and spoke with the general manager and that, and they said, why didn't they tell us earlier? But why didn't someone come up with the thought where you really come from, not that original town? So it was really sad for me. Then I left them and I came back to Bourke, and that poor old lady died in that hospital, you know, and that is sad that she didn't get home to country when she should have. That's another point that I like to put across is transferring people back to the right country. not where they may have been transferred from. And people will tell you that. And another thing, I had another thing about, you know, there was a family wanted to go home to country, and they had their old mum in hospital there in Dubbo, and the Aboriginal health worker rang me up at night, Louise, how can we do this? This old lady's dying. How can we get her home? I said, you know, you need to talk to the family at Dubbo Base and find out, you know, what's happening there. But you always got to have an on-call doctor wherever they're transferring back. And she said, well, I'll wait for in the morning till the Aboriginal liaison officer start. I said, no, both hospitals work around the clock. You don't wait for in the morning, you set your process up now, right here. Go and see your doctor in your local community and ask them, you know, you need this old woman to be accepted back to your community, and then they will get on to Dubbo Base. That old woman was sent home the next morning, and the family was so pleased, and they're still today. They said, Louise, thanks for helping us out, because we didn't know what to do. And people, when they in the situation and being palliative, they really don't know what to do, and they really don't know the questions. So they'll just go along with the medical team sometimes and say, oh yeah, that'll be all right. But sometimes, you know, you've got to, sometimes the medical team got to ask some special cultural appropriate stuff to say, well, we want this to happen for this patient. Sometimes it's not said the right way, and Aboriginal people, some of them will take it on board, and some Aboriginal people don't. But demonstrated an increased awareness of current local palliative care guidelines. Well, with the COVID, it's in the guidelines that you're not allowed to do this, you're not allowed to do that. But I think I find that in some smaller areas, it depends on the health service manager, who may allow whatever people to come into the hospital and work with them that way. But I'm not quite sure about in the bigger facilities. And with the palliative plan that's going into the home, I find that is a bit not right with me at the moment, because we find that when someone becomes palliative as an Aboriginal patient with the families, become palliative in the home, we have a lot of family members who may be on drugs, haven't, you know, they love a palliative patient in the home, because the drug users will go and want their medication and take them. And I've had to deal with a few of those in our community, where we had to get the community health worker to come around and deliver the medication every day to that patient. And then when the community health wasn't working, we had to go and sort out with ambulance to come and deliver the medication to the patient and or bring them into a hospital. So around a lot of medications in the home with Aboriginal people, there are other family members who would steal their medication and whatever. So I find in that other planning, new palliative plan, I don't know how well it will work, but I find that it is very rewarding to be working in with the full team of palliative, because we haven't got no palliative nurse in Burke. It's distributed, like they come out from Dubbo once, maybe every 3 weeks. So it's pretty hard to have a nurse on board, but and I think that's happening everywhere, where we haven't really got the staff to back it up as well, and especially in the rural places, we haven't got that. And maybe, I don't know, in the cities and maybe, but we're still all stretched to the limit of providing this service to people in our communities, and we've got to try and do what we can to support them and the families. But recently I've had people who were palliative, but they went home from hospital and they actually died in the community. And that was more rewarding for me. I went into the home where the person has passed away, supported the ambulance and police who was called there, and they let all the members of the family come into home and to say goodbye to these people, where if you was in hospital, there would have been only one person who was allowed to come in. So that was more rewarding for me to that this case has happened where 2 people have died in their home, and it was more rewarding for the family, and the family really appreciated that that this has happened instead of being in the hospital. So you know, there's little things like that at the moment with COVID that upsets everybody, but I find people who go on home and die is more beneficial for all the families than it is to die in a hospital at the moment. What else can I say? You know, supporting Aboriginal people with advanced care, I don't really see that as much. They really, really don't like that. I think it's all the paperwork and stuff that you got to do, but Aboriginal people, yeah, they don't really like that, and they'd rather just do it their way by themselves until, yeah, they've got a better understanding if they're around all their mob and working together than to do this paperwork about advanced care planning. I find that Aboriginal people really won't ask for help as much either until it's the very end. And I know before COVID that they didn't like dying in the home because of the spiritual things and whatever. And they always wanted to come to a hospital to die. But that's been a bit of a change, you know, since COVID been around. They want their family member at home to die instead of being in hospital, because they know the result that they all can't go there now. And it's a bit hard. But I'm happy to answer any questions at the end and elaborate a little bit more if you like. So, yeah.
Thank you so much, Louise, for that really insightful presentation. And I'm sure there are lots of questions that people will have that will come to discussion during the panel discussion part of the meeting. We'll move on now to Dr. Louise Christie's presentation. Thank you, Louise, for being a presenter at this meeting. Louise is the Palliative Care Service Senior Medical Officer, Western New South Wales Local Health District Palliative Care Services. Louis has been working in regional New South Wales since 1994. He has held a variety of positions in emergency and retrieval medicine, medical administration, general practice, and has been working for the Palliative Care Services since 2011. He is currently involved in the development of healthcare services, providing palliative and end-of-life care across the region. Take it away, Louis.
Thank you. Hopefully you can now see my screen. Hopefully. My little computer tells me that you can, so I'm just going to plug on regardless, and I'm sure people will tell me if they can't. Thank you for the introduction. I'd also, goodness me, I'd also like to acknowledge that I live and work on Aboriginal lands, and I think whenever we're talking about weighty matters such as death and dying, it's vitally important that we do so, because when we look at the way that Indigenous cultures do this business, they often do it far better than we do, and there's a lot we can learn from them. So I've been asked to talk about advanced care planning in time of a pandemic. and how that changes things, and how a pandemic changes things. So how do we talk about dying in times of a pandemic, and what conversations do we have, and how might we approach them? So Stephen Jenkinson, who worked for many years in palliative care in Canada, said at one point that death is so big it should change everything, and dying should too. And if dying doesn't change everything, you can lose track of whether you are or not. So death is big. And I think one of the first things we need to remember is that from the perspective of our patients, the conversations that we're having are not just conversations about something that's small. They're not conversations about a compartment of this person's life. They're a conversation about literally everything. So if death's big and dying is big, then how much bigger is a pandemic, and how much more should that change the conversations that we would ordinarily have? And I suppose the background to this slide is just a reminder that the issues like pandemics are not new to the human experience. This photograph is from 2016, when the mundane activity of building a car park in France unearthed an otherwise unknown grave, mass grave for people who had died with the Black Death in the 15th century. And so human beings have been confronted by these sorts of experiences fairly regularly through our history, although for those of us around the screen this evening, this is a very unusual set of circumstances, an unusual time. So how much should a pandemic change things? Well, the answer is that depends. And that depends on how successful we've been on flattening the curve. You've probably forgotten about flattening the curve. It was a long time ago that we started talking about the need to flatten the curve. But the extent to which the pandemic will change the way that we have these conversations will depend on how successful we are in flattening the curve and keeping the curve flat. We've just this last week seen news reports from Europe and from America that things are taking off again, and that doctors and nurses and others there are wrestling with the questions of what do you do when there are 10 patients who need a ventilator and 1 ventilator to put them on. So the more we flatten the curve, the more we'll keep things the way that we are familiar with, and the more likely we are to run into unfamiliar territory if we're not successful. So when do we talk? If it's important to know how pandemics are different, then it's important to know first about what the usual state of affairs is. So when do we usually need to talk to people about dying as doctors or nurses or healthcare professionals? You know, what are the point of the conversations? What information are we trying to get out of them or trying to impart to them? And what things are we trying to get tied off? Well, if you ask healthcare professionals to think about that for a while, usually we come up with 3 different sets of conversations, broadly speaking. We talk about, you know, wills, powers of attorney and guardianship. We talk about advanced care planning and advanced care directives, and we talk about what happens at the very pointy end of life discussions. And sometimes we don't necessarily tease them out that way, but they're basically the circumstances that people are familiar with. What I'd ask you to do now is for a little while just to take off your trained healthcare professional hat and start to try and look at these conversations from the perspective of the people that we're talking to, and try to understand how they come to these conversations. And what we notice if we do that is that the perspective is very different. So the mechanical legal stuff, wills and powers of attorney and so forth, from the point of view of our patients or clients or residents, these aren't actually discussions about dying at all. These are discussions about serious ill health and loss of capacity, and what are you going to do with all the stuff, or what are the kids going to do with all your stuff after you've died? What are the kids going to do with all the debts you've accumulated after you've died? And generally speaking, a pandemic doesn't change this. And if you need some convincing that that is actually the case, that these conversations are not about dying, then if we have a look at, you know, the Australian government website around the planning for ahead tools, The Planning Ahead tools tells us very clearly that Planning Ahead tools is about preparing wills and powers of attorney and guardianship. And when you have the Planning Ahead documents in place, you can rest assured that your rights and wishes will be respected because they're properly documented. But if you don't have them in place when they're required, a court or a tribunal might get to appoint someone to make decisions for you, and the opportunity to choose who you'd like to act on your behalf will be lost. So it's good to plan ahead. These aren't conversations about dying. These are conversations about an insurance policy or a safety belt. And so often when we think we've engaged in a conversation about dying because we've been talking about wills and powers of attorney and guardianship, that's not how the patients or residents or clients that we look after and their families view those conversations. Okay, so surely when we start talking about advanced care directives and advanced care plans, then we're talking about death and dying. And so perhaps the pandemic will change these, and it will to a degree. So different than an advanced care plan and an advanced care directive. Well, according to the New South Wales Health website in July of last year, and I've added the bold, they haven't, an advanced care plan is written on by you or on your behalf. It documents your values and beliefs and your preferred health outcomes. And the plan's prepared from your perspective and used as a guide for future discussions about your healthcare if you're unable to speak or otherwise communicate your wishes. And an advanced care directive is pretty much the same. It's just that you're the only one who can make it, and once you've made it, if it's a valid legal document, it must be followed. And from the same website, advanced care planning is important for all of us. It involves you and your loved ones and health professionals talking about your values and what care you'd want to receive if you became seriously ill or injured and were unable to say what you wanted. Ideally, these conversations start when you're well and continue throughout your illness. So if you're someone without medical training and you're reading a lot of this stuff, your assumption often is that we're not actually talking about dying. We're talking about being sick or injured and unable to say what you want. If I got knocked unconscious, for instance. And they start when I'm well and they continue throughout my illness. So presumably when my illness finishes and I get better, then we can put the conversation back on the shelf again. So it's important to remember as healthcare professionals that even when we're having conversations about advanced care planning, from our patient's perspective, they may not yet be talking about death or dying. And again, if you're not quite sure that that's the case, if we look at the Advanced Care Planning Australia website, they say very clearly, if illness or injury, temporary or permanent, prevents you from making decisions about your healthcare, advanced care planning makes sure that your values, beliefs and preferences are understood and respected. So quite often patients come to these conversations assuming that we're talking about serious illness and serious injury that may be temporary and that they might get better from. And so again, it's not always clear to them, even when we're talking through the issue of advanced care planning, that we're talking about the possibility of death and dying. And if you really need some convincing that I'm not making all this up, this is from the front page of a prominent advanced care planning organisation that operates in Australia. And their tagline is, take charge of your life with an advanced care plan. Now, I don't know that taking charge of your life has anything to do with your dying. So, does that mean we should stop advanced care planning? Well, no, we shouldn't. Advanced care planning is very important. The reason advanced care planning is important is because it helps us as people working in healthcare to start the difficult process of taking someone who is certain they're going to be alive tomorrow, and because of their diseases and other infirmities and so forth, helping them to come to a point where they understand that they are someone who will die tomorrow. And so it's one of those tools that we can use in helping people to start to think about their mortality in a fundamentally important and useful way. as long as we approach it in the correct manner. So when you sit down for an advanced care planning conversation with somebody, it's important to remember that they will bring a set of assumptions to the discussions. And those assumptions may be that this is nothing to do with dying, this is just to do with being sick and getting better. Be aware of the language that you use and what the language says. Be very clear and concise and careful in what you say. And these conversations often take a lot of time and you need to have a lot of space for reflection. And it also helps if you can mention at least once the possibility that this person might be dying or might be going to die. And that way we can start heading in the right direction. So then, I know I haven't spoken much about pandemics yet, but we'll get there in a minute. So how is an advanced care directive discussion different from an end-of-life care discussion, and does that matter? Well, they are subtly different, and often we as healthcare professionals will miss what the difference is. So when you're coming to an end-of-life care discussion, if you're a patient and family or a resident or a client, then you understand that medicine has its limits. You understand that not all treatments are going to be beneficial. And most people come to those conversations with the assumption that the doctors looking after them are only going to offer them useful treatments. And quite often they'll come away from a conversation with the impression that they should take whatever treatment's been offered because the doctors offered it, so it must be useful. As doctors or nurses or other healthcare professionals, we come to those conversations with the unstated knowledge that medicine has its limits. Not all treatments are going to be beneficial, but often we assume that patients have come to us because they want us to do something, and we tend to be people who are good at doing things, and we like to be helpful. And it's a very uncomfortable space for us to be sitting in if we feel that we've offered them nothing. And so often those sets of assumptions will result in a conversation that becomes very awkward. The important thing and the important reason that pandemics change these discussions are that in a pandemic, the medicine may reach its limits very quickly. And the limits are no longer set by what the pharmacology or the technology can do for the specific problem for the patient in front of you, but the limits are hit because of the service capacity to deliver care and deliver resources. And so the big difference in a pandemic is that we will start entering end-of-life care discussions much earlier, particularly if we lose the ability to suppress the curve, and we start finding that we're getting more and more cases than we can realistically look after. So an end-of-life care discussion, when you think about it that way, regardless of whether we're in a pandemic or not, is no longer a discussion about what you want if, which is often how we frame these things. It's a discussion about the limitations of medicine in the current situation, irrespective of what the patient might want. So it's a conversation about what we can actually do, not what you want us to do, or not even what we would want to do for you necessarily. So an end-of-life care discussion is the discussion we have when we reach the point that the medicine has failed them and us. So the medicine's betrayed its promise to them and to us to always cure people and to restore them to health. And so it's a discussion that is as much about dealing with that betrayal as it is about the technical aspects of medicine. So how do you do that? Well, when the medicine fails you, all you have left to do is to draw near to the bedside and be a decent human being. Because if the medicine's failed you, then the medicine's failed you. And it doesn't matter how much medicine you know. And at the end of the day, dying is not about medicine, it's about being human. And Louise has already spoken about the elements of being human and being Aboriginal in the business of dying, in the place in which we live. So at the end of the day, end-of-life care discussions aren't actually about medicine at all. They're about being human. So people usually shudder at that point and say, well, how do you do that? Well, the good news for us is that if you're a doctor or a nurse or another healthcare professional, people actually expect you to talk about the medicine anyway. So that's a reasonably good place to start. What we need to do is to be able to talk to people honestly and openly about where we are really. You know, what can aggressive management offer them now? And what are the limitations of medicine in the circumstances that we find ourselves? And why has the medicine failed us? Or maybe why do we think the medicine is going to? And the difference in a pandemic is that quite often the limitations and the failures of medicine aren't going to be about the management of a specific disease necessarily, but they're about system capacity sometimes. But it's not all about system capacity. And that's the other thing that we have a job to explain to people. So a lot of people are of the view that only the young people got into intensive care because there was a bias against old people. Actually, the reason that only young people got into intensive care is that the experience coming from around the globe is that universally old people or older people with COVID, and the older I get, the older old is, have a very bad mortality, have a very high mortality rate with COVID. So what do we know? What's the medicine that we can talk to people about? Well, firstly, mortality does seem to vary from country to country, and we don't yet understand why. So pretending that we do is not helpful. There's probably some reporting artifact. There may be different viral mutations. There's probably cultural and socioeconomic factors playing into that. But we see that mortality in different countries is different. However, if we try and strip as much of that away as possible, in New York, as a useful bit of data, so far, 80% of the patients who have been ventilated of all ages due to COVID have died. So if you get onto a ventilator in New York because of COVID, you're 8 out of 10 times you're going to die. You're not going to be extubated successfully. And that's for all ages. And ventilated survivors are often ventilated for very long periods of time, 4 weeks or more. The other thing that we know from the palliative care experience, and this seems to be constant, is that symptom control seems to require substantial doses of medication. And that's something just to be aware of. When you look at the guidelines around managing COVID-19 from a palliative perspective, people are often a bit surprised at the doses that are being suggested. And that's because the experience seems to suggest that these people need a lot more than you would usually give. The other thing to remember in the population that we're talking about, the aged population, is that the mortality is much higher regardless. So of all identified cases of COVID-19 over 70, the mortality rate is somewhere around 10 to 15%. The older you are, the more likely you are to die. So the older you are, the higher that mortality rate is. But the important thing to remember is that if people become sick enough that we would ordinarily consider getting them to hospital, then the mortality rate in that group is very, very high, even if they do get to hospital. And if they get onto a ventilator, they almost universally never get off. And this is one of the reasons that there has been a reluctance to ventilate very old people with COVID, regardless of their premorbid function, because the data seems to suggest that they don't do well. My helpful computer. So how can I start talking to my patients about that? How can I contextualize that for them? There are some useful tools, and those of you who've heard me talk before will have heard me talk about the SPICT tool from the NHS. It's a really useful tool. It doesn't give you a percentage chance of dying, but what it does do is give you a useful piece of paper that includes a number of particular indicators of likely mortality in the next 12 months. So it contains a number of indicators of physical frailty that we know are associated with significant mortality in the next 12 months. So if you've got somebody and you're trying to talk to them about where they're at in the trajectory of their disease and their aged frailty, then often being able to sit down with them and their family and go through with something like the SPICT tool and start looking at where they're sitting, the more markers they get of frailty, the more likely they are to be dying soon. And so that can be helpful in providing some structure for you and some certainty that the person in front of you who's not looking that bad today actually does have a number of things which are flags for mortality in the near future. So then how do you approach that discussion? Even with all that information, how do we then take someone through that discussion? The important thing is to explain to people the limitations of medicine and only offer them treatment which is likely to be a benefit to the patient, or which in a pandemic the patient's likely to be offered. There's nothing more distressing for a family to have someone transferred in to a hospital with statements to the effect that when you get to hospital they'll put you in intensive care and so forth and so on, to then be told that we're not going to put you in intensive care because you're too unwell. That creates all sorts of conflict and distress that we don't need. So when you're approaching an end-of-life care discussion or an advanced care planning discussion in a pandemic, we need to look at where the medicine is sitting and what the pandemic's doing and what the limitations of medicine are, and we need to carefully explain those. It's also vitally important that we make it clear that the decision not to proceed with ineffective therapies is a medical decision. Don't ask the patient or the family to carry that burden with them. Often, because of our familiarity with advanced care planning discussions, where we often ask the question, what would you like? In an end-of-life care discussion, we're often past the point of what would you like? But if we ask that question, the family assume that there is a choice and that the choice will make a difference. About 5 years ago, I was working, I gave a talk in Orange that I was asked to give, and afterwards a man came up to me to talk to me, and he said to me, the worst day of my life was when they came and asked for my permission to switch off the life support machines on my dad. And his father had died about 25 years before that conversation, and he had understood for the last 25 years that there was treatment that would have been beneficial to his father, but the doctors had suggested to him that it would cause so much suffering that he should forego that treatment. And therefore he reluctantly agreed that he would forego treatment that he thought would cure his father, because he thought his father would not be able to stand the suffering. And so he understood for 25 years that he had effectively signed his father's death warrant. And 25 years later, in talking about it, he was still overwhelmed by being distressed. So it's important that we don't burden the families and patients with the sense of there being a choice if there isn't one. We need to be prepared gently to take that burden from them and to carry that burden as healthcare professionals. And that's often a difficult thing for us. And that really brings me to the conclusion of what I was going to say. So advanced care planning and end-of-life care discussions in a pandemic are in many ways much the same as advanced care planning and end-of-life care discussions outside of a pandemic. The difference, though, is that we will reach that point where we have struck the limit of medicine earlier if we're not successful in containing the pandemic. And the best way to deal humanely with the people that we look after in that circumstance is to be honest with them about the limitations of medicine, not just in their situation, but broadly speaking, and to help them navigate the very difficult circumstance of not being treated if that's the appropriate thing to do. And if we're all diligent and keep washing our hands and meeting by Zoom, then hopefully none of us will be faced with that difficult decision of having 10 people who have good prospects of recovery and one ventilator to fit the 10 of them. Thank you all.
Thank you so much for that presentation, Louis. We'll move on now to the panel discussion. Joining Louise and myself will be Dr. Sarah Wenham, Specialist Palliative Care Physician for the Far West Local Health District based in Broken Hill. And we'll also have Tabitha Jones, who's a COVID-19 Project Response Coordinator for Western New South Wales Primary Health Network. I'd like to just kickstart the panel discussion by a question posed to Louise. Louise, this question came from Susie and is really pertinent question. When we have an Aboriginal resident in aged care, so in an aged care facility setting, it's not always easy to have them move to another home that's closer to where they may have come from, to move them back to country. Do you have any suggestions and comments around that?
We have had people who have come back to country, whether it's come by ambulance or by road, or, you know, if they can sit up in a car, the family will go and get them. But yeah, majority of the time people love to come back to country to die.
And in that sort of setting,
Family.
yeah, and in that sort of setting, Louise, would you see that happening best as coming home to, you know, the home of the family members back to country, or more so a hospital facility?
It would probably be more so a hospital facility. Depends on how much the care is needed for that patient and what they've got to do. If it's all medical, but otherwise, yeah, I'd see them go back to a hospital, because then if they're dying, then they become palliative. So there's no more medical stuff for them, and they just bring them home and leave them there until they die, like as a palliative patient.
Thank you for that response.
Mm.
I'd like to ask Louis and Sarah, I don't know who would like to jump in first, but your experiences of people in the hospital and also in the home setting and aged care facility settings, when they're Aboriginal in background, have you noticed a significant difference in your experience with how best to manage people? Sarah, I think you might be on mute.
Sorry, I still am on mute. I do apologise. I knew I'd do that. I had myself on mute twice so that I wouldn't disturb Louise' wonderful presentation, and thank you for sharing as well, Louise. Look, I think out here in the far west, we are really blessed with some fantastic Aboriginal health workers who really support us to care for our Aboriginal communities at the end of life. And I think I've also been very blessed by years of very patient and strong relationships that have been built up between the palliative care service and our Aboriginal communities, not only in Broken Hill but in all of our smaller remote districts as well. So I think the thing that I've learned is I suppose firstly that we, as Louis mentioned, you know, when we are caring for people right at the end of life and their families, it's about bringing us as humans to the bedside and connecting with people. And I think in that way, for me, it's no different to caring for any other patient I care for. However, being very, very mindful of the things that are very culturally important to people and doing that in a very sensitive way. And so I would, first of all, I think would never go and see an Aboriginal patient without one of our Aboriginal health workers, whether that's here in the hospital or whether it's going to their home with a member of the clinical team from our local AMS or from the local health facility. If it's in an area, they're often able to give me a lot more background and just help me to address the things that need addressing in a sensitive way. And some of the things that Louise mentioned about, you know, is it safe to put certain medications in the home, those sorts of things is also really helpful. I think, you know, just being open and asking what's important to people, exactly as Louise said, you know, how do we know what people want unless we ask? And so do people want to be on country in the hospital? Do they want to go back to their local facility? Do they want to go home? And we've cared for, and we've got, you know, members of our Aboriginal community home from Adelaide. We've got them from Broken Hill back to Wilcannia, back to Menindee. Sometimes with with a very short period of time, because I think what happens is everybody really does pull together, and we've recently had a gentleman die at home in Wilcannia, 200 kilometres away from the nearest doctor, with us supporting them remotely here from Broken Hill, with on the ground. In hours, it was the local Aboriginal medical service. Out of hours, it was the local MPS staff. And so we have managed to care for people physically at home if that's where they want to be, or back in their community. I think the other thing that I've really learned, and again, it's really been through the generosity of the people that I've cared for and their families, is actually understanding what's happening. And I remember there was one, it was about 2 days before Christmas, and we had a young Aboriginal girl who wanted to go home to her local community to die, and I just wasn't sure whether she would survive the 100-kilometre trip home. And the Aboriginal health worker said to me at that time, Sarah, it doesn't matter if she doesn't get home. The fact is that she won't be in the hospital and she'll be on her way back to country. That's what's important. And for me as a doctor, the thought of somebody dying in a car or in an ambulance on the way home was, that was upsetting for me. And I suppose I just then had to understand that actually that was my distress. That actually wasn't her distress, and it was more important for her to be on her way home to country. That girl got home, but that was a real learning for me a couple of years later, when we had one of our Aboriginal elders who was in hospital in Adelaide, and it was very clear he was dying. And what we actually managed to do is to get him in an ambulance, in an aeroplane on the way home, and he did die on the way home, but he died in the aeroplane, having left South Australia, and on his way home in the aeroplane to country, and he knew that, and that was absolutely the right thing for him, for his family. And yes, I think it's finding out what's right for that individual and where it's right for that individual person to be, really pulling out all the stops to make those things happen. And you'd be amazed at how people will pull together to make things happen when we know what people want because we've asked, but also about listening to the people that know that our patients, listening to our Aboriginal health workers, listening to their families. And now they'll often be the ones that if at 8 o'clock in the morning I walk in and I've got Pete or Hayley standing outside my office, I know we're going to be in for a big day, but they know that they can now come to me with what the patient, their family wants, and they know we'll do everything to make it happen.
Thank you so much. Yeah, and it highlights the importance of really using our listening ears and not making assumptions. And I guess for different individuals and different families, their wishes may be slightly different as well. And you've highlighted the importance of bringing an Aboriginal health worker into the discussion. I'm going to ask, in terms of access to Aboriginal health workers with palliative care background. Louise, I gather you're pretty unique across the whole of our Western New South Wales footprint. Have you got other colleagues that we as GPs can tap into as well? Should we be needing assistance from an Aboriginal palliative care perspective?
Any Aboriginal health worker in anywhere in the state of New South Wales or anywhere, they're all attached to palliative. They've been working as health professionals for a long time, and they adapt to the needs of their community and their families and whoever, but any Aboriginal health worker will help you.
Yeah, thank you.
They know their community, they know their family, they know the situations, they know what people want. You only just got to ask them, and they were there, and they will let you know how to deliver for that person. So they've got the best knowledge of their communities, their people. Why not ask them?
Thank you.
Just to add to that, I suppose I spent this morning in a meeting with the LHD looking at the specific issue of Aboriginal health, and one of the things to come out of that discussion was a pretty universal agreement that we don't have enough Aboriginal healthcare workers, and we need to have increasing that workforce and diversifying that workforce is a priority. So yeah, it's one of those things that it's interesting. I hope that in 5 or 6 years' time, we'll be at a point where talking about it is unremarkable because it's all happening. That would be nice.
Yeah.
And if it's about getting more health workers, that's the only way we're going to close the gap. Like, the gap's not closed yet, so, you know, it's still a bit wide. And employing more Aboriginal health workers, just like I got an email the other week about we need to put Aboriginal health workers into the surgery area because getting Aboriginal people to come in and have their surgeries, it's not really happening as much. But if you've got an Aboriginal worker who is working around surgeries, well, and explain and tell them all the legal stuff about being operated on, and that'll be a big plus for our LHD as well.
Yep. Could I also just pick up briefly on the thread that Sarah was talking about? Often when we're asked to come in to assist an Aboriginal patient or family in palliative care, there seems to be a lot of anxiety often that people don't understand the detail of the culture. And the question is, well, how do we do this culturally appropriately? And as Sarah said, and as Louisa said, I don't need to understand a lot of the detail of the culture. I just need to be open to asking the questions. And people will tell me what I need to know. And there are things that it's inappropriate for me as a white male to know about the business of dying amongst Aboriginal people in our communities. And so it's really about me allowing them to tell me what I need to know to do what they need me to do, but I don't need to know everything. And I think if we approach it in that way, where we're asking people very openly, what is it that I need to do for you? And what do I need to understand to do what you need me to do? Usually everything comes together quite nicely.
And that also can go to any culture.
Yeah,
you know, that we have in our facility. We've got all different cultures that are in our facilities. So it's not only Aboriginal, but all the other cultures that may be a bit similar to Aboriginal culture.
And Louise, that's such a good point. I remember as a JMO, the difficulties with an Italian family who had not wanted our team to let the patient know that she had end-stage stomach cancer. And it caused a great deal of difficulty amongst our young, and we were very young. It was the intern and resident and registrar trying to make a decision about what the right thing to do was. And yeah, that aligns with your comments there about the differences between different cultures, and really it's about asking that question and understanding what works best for that patient and that family.
It may not be about a patient, it may be about a staff member. I know at the moment, like we've got a lot of Indian staff, they deliver differently to normal staff when someone has died in the ward, and their culture is different. So I always look around and see, well, how do we culturally do this with our staff members? That's another thing,
Sharing the expertise.
Yeah, but getting their ideas, how they do stuff when people are dying.
Yeah, thank you. Louis, there's a question that has popped up, and it's a specific question around, are you still offering a couple of days experience for GPs if they want to get to tag along with you with palliative care?
Yeah, so both, I think I can speak on behalf of both Sarah and I that we do that. We do that usually through the PEPA placements, PNPA, the Program of Experience. I can never remember program
of the experience in the palliative approach.
Palliative approach. There we go. Now you'll remember that, hopefully. So yeah, that provides some funding for backfill to make to financially support GPs, nurses and other healthcare professionals come and work with the Pal Care team. But yeah, so we do placements, and I know Broken Hill does as well, and we'd always be happy to see people.
Fantastic. Sounds like a great opportunity. A couple more questions. Louis, you referred to the fact that for people with COVID, symptom control might require substantial doses of medications. What sort of dosages are we talking about there?
I mean, the two when we look at the symptoms that people are having trouble with, it's usually the respiratory distress and the agitation. And people are talking to people, particularly in New South Wales, and we had one COVID death in Orange. So it was the fairly standard medications, morphine, midazolam, so forth. But the doses we were using were, you know, people were getting 10 milligram aliquots at a time and fairly regularly to try and get on top of things. So there are guidelines out through the PHN, through the LHD as well, and there are New South Wales guidelines. So there's lots of guidelines you can follow, but one of the comments when people first look at the guidelines and start thinking about implementing this in the patient in front of them, one of the questions that has popped up is, that seems like an awful lot of stuff. And the answer is it does seem like an awful lot of stuff, and it seems to be an awful lot of stuff. I suppose the other thing that comes out of that for particularly aged care facilities, because we've had this question a few times, is that the trajectory of COVID seems to be a relatively mild illness for a few days and then a crash. And so the vitally important thing, if people are having patients who are COVID positive and they're looking like they're having to keep them, is when in that 72 hours or 3 or 4 days or maybe 5 days where they've got relatively mild symptoms, that's the time to make sure that the advanced care planning and the end of life care discussions have happened. That's the time to make sure that the scripts have been written and the medication's been obtained, and you've obtained about twice the medication that you think you're going to use. And so you've prepared, and you're not trying to chase it when the person starts to deteriorate, because the natural history of the illness seems to be that when people crash, they crash spectacularly and within 6 to 8 hours. So often there's not a lot of time to do a lot of preparation once they go. So it's really about having all that stuff in place beforehand.
Yeah, thank you for that. And I'm just mindful of time, but I'm just going to sneak in one last question. And maybe Sarah, if you'd be happy to answer this one. I think we're often in that position, and particularly with aged care facility residents, where advanced care directive has been written at some point in time, but it comes to that crisis situation where somebody's health and well-being has really taken a rapid downturn for the worst. And then not infrequently, we have family members sort of creating some pressure around that point in time to go against what the initial advanced care directive was, and to actually grab an ambulance and transfer to hospital. What are the magic words we should use in that situation to make it okay for the patient and the family?
Oh, crumbs. I honestly don't know whether there are any magic words as such. I mean, I think for me, sort of just taking it a little bit of a step back, I think sometimes the times when I've found it most difficult has been when that particular family member may not have actually been involved in the previous discussions. So I think just taking it a step back I think it's really important that we use advanced care planning not just as an opportunity to get a piece of paper written, but actually it's an opportunity to have a discussion. And as Louis said, this is actually around not only the patient or the resident, but also their family, and there are people that are near and dear to them, and it's not just their enduring guardian or their person responsible, but other people that may be involved in the decision making, that they're actually involved in that earlier on and when those discussions are being had. So I think that would be my first thing, is to really try and involve the key people right from the very beginning, and keeping advanced care planning as a dialogue. So, you know, for me, advanced care planning is not just a one-off, write a document and we're done. You know, people are allowed to change their minds. We know from all the research evidence, as people live for longer, as they get more frail, that their wishes and their choices change. And I think sometimes if family are going on that journey with their relatives, again, sometimes it is easier when people do crash. But I think, yes, you know, there is always going to be those occasions, and I think for me it's like anything in a crisis. I think it's trying to find out what is behind that response and those requests from that family member. And I think sometimes if we can then find out what's behind that, we can then actually support those discussions, and often then ultimately bring them back to what their mum or their dad or their sister or their loved one actually said when they were well, and try and get them to think about it not in terms of we're dealing with their distress at seeing their loved one acutely unwell, or certainly here in Broken Hill, I don't know what it's like in Western, but certainly here in Broken Hill we often find, again, maybe it's the relative that doesn't live here anymore, that hasn't seen them for a few months, and so they've not been on that journey of deterioration with them, and it's been a really big shock when they've got here. So acknowledging you're dealing with their distress, but trying to help them to understand what mum or dad would have wanted. They told us what they wanted, and actually it's our responsibility to sort of understand their wishes, but also like Louis was saying about, you know, acknowledging the limitations of medicine, and being human, and trying to sort of say, well, we could do this and we could do that, but what's the likely outcome? Would we be able to sort of improve them to the extent that mum or dad would want? Or, you know, last time they were in hospital they were really distressed by that, is that, you know, and so I suppose it's just drawing on previous experience. And I think sometimes the other thing is sometimes, you know, plans do change, and we do sort of do a trial of this and a trial of that sometimes, because I think we also, you know, do need to bring people along. And ultimately, I think it goes back to what document do we have? If it's an advanced care directive that's been written by a competent person, then we are legally bound to follow that. And I very rarely have to, you know, be quite, you know, use that type of terminology, but at the end of the day, you know, that's our responsibility. As Louis said, we have to take that medical responsibility sometimes, and it's our responsibility to interpret and to use a legally bound document. If it's an advanced care plan, then it's an expression of somebody's preferences and wishes if they're not able to express those for themselves. So, you know, sometimes there is a little bit of negotiation and a little bit of trial in order to bring people along. But I think at the end of the day, for me, it's about, you know, focusing on the patient or resident and what they wanted, and trying to bring the family along. Sometimes, you know, we succeed, and I think sometimes we don't, and then I think it's about using the team that's around us, and you know, maybe some other members of the team, you know, have different ways or different magic words, or just come in on a different day or a little bit further down that journey as well. So you know, I think if you're not able to take that conversation, draw on the other people that are around you that could maybe support that conversation as well. I don't know, Louis, whether you've got any other magic words or bright ideas.
No magic words. If I had the magic words, I'd have written a book a long time ago and retired. I don't really have anything to add to what you've said. It's one of those things. It's how we manage the distress.
Yes,
it's difficult.
Thank you for the great points. I think for me, in a GP role, what that highlights to me is really ensure that we have those discussions, and that those discussions particularly relevant to the COVID situation at this point in time with the patients that we look after, engage the families in the discussion, ensure that we say, you know, in the setting that you, if we're talking about the patient, if you contract COVID-19, this is what it might look like, and what are your wishes around that, and to make sure that the families have an understanding about that. Certainly one of the big things I know that had arisen in the Melbourne setting, I mean, it was a horrible media around saying that, you know, people weren't looking after the elderly because they were refusing them transfer to hospital, and it was just such a poor media statement around that, because it didn't take into account people's individual wishes as to what would work best for them. So I guess for us in New South Wales, where we have been in the fortunate position, certainly in Western and Far West New South Wales, not to have to be in that situation. I guess now's a timely period to ensure that we do catch up with our elderly residents and the family members about this. A couple of quick questions. Katie, I hope that's okay. One question is, what discussions are happening between aged care facilities, local health districts and GPs about transferring COVID positive patients to hospital? Tab, I think you'd be fabulous at answering that one there.
And this is actually something that we have been doing a lot of work around this week in Far West, but also in Western. So the LHD has been facilitating some really fabulous scenarios, and we're doing them specific to the facility, so facility by facility generally. So for the people here from aged care that want to get involved with that, the desktop scenarios, that's an option. And it really is about having that sort of three-way conversation between New South Wales Health and driven by the public health unit, because they're going to be very heavily involved in an outbreak in aged care and give a lot of direction around that, which is what we need to happen, as well as the local GPs who are going to still need to be really heavily involved in care. And we've seen that where there's been outbreaks, not only with the care of COVID positive patients, but their regular patients who still need all their care attended to, and the facility, because there's a lot of fear around this aspect, around what's the right thing to do. And there's also probably a lot of media around transferring and not transferring patients. So the question sits really, and it's a hard one because it's probably going to be case by case. And as Louis talked about, it's going to really depend on that curve too, what's happening with the rest of the healthcare system. So it's really hard to sometimes sit with the ambiguous question that we need to look at it when the time comes and make the best decisions when the time does come. But I guess that's what will happen. We'll transfer patients where it's needed. So we've had conversations around potentially where we don't have palliative care or RN services to support the facility. There might be a higher need, but there might also be the skills in situ to keep some of the mild to moderate or the palliative care patients within the facility and respect their wishes for dying in their facility. So it's a tricky one, and I don't think there's necessarily a right or wrong answer, and Sarah can probably talk to that more, but it will be case by case, and it'll also depend very much on what's happening in the wider community and healthcare system and the resources that we have, because we can't possibly predict where we'll be at with it. And I would just say, yeah, encourage anyone that wants that conversation facilitated, get in touch with us, because we can have it and just give you some supports and some ideas about how you might work through that scenario, and who's available to help you, because there's the PHN, New South Wales Health, the public health unit all want to be there to help you with the decision making and the best decisions for the patient. But I will just sort of spin this back into a question for Louis, because the facilities do talk to me a lot about what happens in a COVID or a pandemic situation when potentially the patient's wishes might be to be transferred or might be to end their life in the facility, but the COVID situation means that maybe that pathway can't be followed for one reason or another. Do you have any advice on that?
Yeah, it's something we've given some thought to. When back in March, locally we set up a system of rounding with the nursing homes on a weekly basis or twice weekly basis, really, so we could, and it was usually a remote round, so we could identify the people that we thought might be going to crash. And the plan was going to be that we would have that window of 4 or 5 days once someone had been identified, and we could start working out what we would do, and we would have the opportunity, if we thought it wasn't going to be feasible to move them into the hospital because there wasn't the capacity to do so, for us to come out and for us to take over that issue of talking to the family and the person and anyone else involved around the situation at the time. I think what you've said's entirely correct. It's the challenge with this is the ambiguity and the fog, and it really depends on what is happening with the caseload broadly. So it's going, it'll become a challenging time for us if it all takes off again like it has in other places in the world.
Yeah, I think the only thing I'd add to that is I sit on a number of state committees, and I just want to reassure people that there aren't, at a state level, there are no blanket policies that will be transferring everybody out or not, or keeping everybody in the nursing home, because I think that has been some of the media concern that has got out there. So I think just from a state level, just to reassure people that there isn't a blanket stay at the RACF will transfer everybody out, and absolutely it is going to be on a case-by-case basis depending on where we're at in an outbreak and a pandemic. But that being said, as Tabitha's mentioned, we've done sort of desktops every night this week with our different facilities in our different areas, and whilst it is on a case-by-case basis, yes, there is a huge amount of planning that has gone into looking at every possible scenario about keeping people at the residential aged care facility, if that's their wish, about transferring people to hospital. In some of our more remote sites, how do we transfer people interstate and out of area if they need to, if they're clinically unwell and they need that higher acuity care. So whilst yes, it is on a case-by-case basis, just reassuring people that has been a huge amount of planning and will continue to be as the situation changes, so that we can and have planned for every potential outcome or scenario that we've possibly thought of.
Thank you, Sarah. It's 8:15 and I'm mindful that we should probably wind up now. It's been a really interesting panel discussion, and thank you all for your really insightful responses. Just bringing things to a close at the moment, there should be a QR code that will appear any second now, which you've got the opportunity of scanning that with your smart device camera, or alternatively to click the evaluation link that was sent to your inbox. And we really look forward to receiving your feedback for this session. Thank you for joining us all tonight, and enjoy the rest of your evening. Good night all.
Thank you, everyone.
Thank you.
Thank you, everyone. Have a lovely evening.
Yeah, thank you.